point. And again, received all of this funding. So she has a lot to talk to us about today, and I hope you enjoy it. Thank you.
Thank you. Thank you for that introduction. I think I'll take you around with me. You make me sound really great. Well, it's a privilege and an honor to be here today to talk to all of you about something that I think is really important for all of us, no matter where we are on the trajectory of our careers, which is really communicating about goals of care with our patients. And as Carrie mentioned, I'm here supported by the PCORI grant that we'll talk a bit about. So we'll talk a bit about why communication is important, and hopefully I will impart some new skills that you may not have heard of before to use when approaching goals of care conversations. So, how many of you in here communicate bad news? Yeah. And for how many of you does it sometimes feel like this, right? So let's imagine this is the doctor here holding the bad news, and this is the patient, and you're all sort of avoiding each other. Giving bad news is challenging. Why can giving bad news be challenging sometimes?
You don't want to get the patient mad at you.
Yeah, right? You don't want people to be upset. You don't want to do harm. That's right. You don't want to feel like a failure. Absolutely. Absolutely. Particularly in our field of cancer, where, you know, we go into this because we want to do well. We want to help patients. We want to help them live longer. And when you have to give bad news that the treatment that you had to offer is no longer helpful, sometimes that can be really challenging to do. Other things that come up sometimes, this emotion, you know, anger, sadness, my sadness, my anger, your sadness, your anger, and how am I able to sit with you in the moment and get you through those things. Fear of destroying hope, right? That's a big one that we hear a lot. And that patients say to them, you know, doctors, are you giving up on me? No, instead we're trying to say, you know, I'm here with you, and what I'm also asking is, tell me what's important to you with the time that you have left. And so what I hope you will take away from this is that there are real skills that you can use to be better communicators. And so I'm going to admit that I haven't read the whole book yet. I'll put that out there. But the parts of it that I have started to read so far has been very interesting. And so this is Atul Gawande's book on being mortal. And one of the things he says really early on is, I learned a lot about things in medical school, but mortality wasn't one of them. And that's this idea that we're really not taught how to communicate with patients. There's this idea that you become a doctor because you're good at it. You have a good bedside manner. You care. But the truth is, I'm still under 40, so I like to think that I'm still really young. And I never learned this in medical school. I didn't learn it in residency, really. Truth be told, I didn't learn it until I really took the time in a palliative care fellowship to learn the skills that are important. And I think that that's a huge failing of our system, and it's something that's improving. So this, on Newsweek, the case for killing Granny, right? This is the death panels. All the ACA said, the Affordable Care Act said, was, let's pay doctors to have these conversations, because these conversations are really important and they take time to do. And they take more than that little 15-minute visit I'm going to schedule in when I have to talk about all of your complications from chemotherapy. And yet it turned into this, we're killing Granny. And now this has come around full circle, because now CMS has approved the codes for advanced care planning, and as doctors, nurse practitioners, we will be able to bill for that time. You know, the question is, what will that look like? What will I have to actually document I did and I said? And what's interesting that we were talking about earlier is, even if I document I did and I said something, how do I know I actually did and said something? And that's where this comes into play, to give you the tools and the skills that you will need to use to actually have those conversations in a meaningful way. So what we end up talking about with patients is half-truths and misinformation. You know, I really hope that I can send you to rehab so you can get stronger and come back for more chemotherapy. I've certainly been guilty of doing that. I've seen other people say it, even when you know that the underlying disease in which you don't have further cancer therapies for that patient then going to rehab when their cancer is not getting treated isn't going to make them better. But it is our inability to say in a way that is both comfortable for us and gives comfort to the patient to give that bad news and that information. Lack of clarity for appropriate goal setting. So patients end up dying in ICUs, right? We know that the majority of Medicare spending happens in the sickest 1% of patients. And I'm not saying that's not appropriate. I think we probably should spend money on the sickest patients in our population. The question is, what are we spending that money on, right? And we're spending that money on the 20%, particularly of patients with cancer who end up dying in the ICU, right? We end up spending that money on the 30% of patients who get chemotherapy in their last months of life. But where we don't end up spending that money is on the 30% of patients who don't get enrolled in hospice before 3 days at the end of their life. And so that's why communication is really important. So, 81%. 81% is the number of patients in the CAN-CORS study that was published in the New England Journal of Medicine of stage 4 colorectal cancer patients who believe that their disease is curable. 11%. 11% is the percentage of patients of doctors and patients who have concordant ideas of prognosis. So in this study, patients went in and talked with their doctors and they came out and doctor said, this is what I told the patient, and patient said, this is what my doctor told me, and only 11% of the time were they both giving the same values. 37%. That's the number of patients who have goals of care conversations. And when those goals of care conversations happen, they happen within 2 months of life, and they happen with doctors who aren't their oncologists. And that's a problem, because oncologists are the providers by whom cancer patients feel the most connected to. We should be doing this conversation, and we should learn how to do it well. So we end up not doing this, right? Which is this giving bad news in this background of really lovely, fluffy flowers, right? That's what ends up happening. So what do patients tell us? Well, patients almost always want direct, truthful information. I'm not sure how many of you were Big Bang Theory, that's my other favorite show, but how many of you were How I Met My Mother fans? And to totally tell you something about myself, I used to watch Buffy the Vampire Slayer. So Allison Hannigan and I go way back. But this was an episode in which Marshall wants to hear all of the information, and she's just there totally crying, can't hear anything. The doctor wasn't meeting her where she wasn't getting a sense of what her values were and the type of information that she wanted to receive and how she wanted to receive it. And so we worry that we take away hope, but we know from studies that that's not true. So even when you have truthful discussions that talk about, overall survival, progression-free survival, the things that we as oncologists talk about, hope doesn't change. Before, you gave all of that prognostic information, and after, hope stays exactly the same. It is the way in which you give the information that matters. And so this is a study by Alexi Wright. It was the Coping with Cancer study. And they looked at about 123 patients with advanced cancer who received counseling and 209 who hadn't. And what you see is that when you talk about advanced illness and you make preparations and planning, when you get counseling, that patients are much more likely to have their preferences and plans written down, documented, and discussed, as compared to when you don't have those communications. And that translates to care that gets received in the last week of life, so that patients who had these discussions were much less likely to be in the ICU before death, to be on a ventilator, to be resuscitated, to receive chemotherapy closer to the end of life, and were much more likely to receive quality services like hospice. So hopefully I'm showing you that having communication with patients about their goals, their values in the setting of an advanced cancer is important because we know it helps them document plans, and we think it translates to quality of care received. Now, most people probably know this study. This was Jennifer Temel's study, of which Tom Lynch, who used to be here, was a senior author. And in this study, she looked at patients with advanced lung cancer, and they were randomized. So half of the group got usual standard lung cancer care, and the other half of the group got care associated with having a palliative care consultation within 8 weeks of diagnosis. So they saw the pal care doctor once a month on average. And this is what we saw. It was a secondary analysis, but clearly survival was better in those folks who had early palliative care compared to those who had standard care. And as a lung cancer doctor, I can tell you that if this was a newer targeted agent, it would have been approved by the FDA, and we would have been giving it to everybody. But yet, we still have to prove what was in this palliative care syringe, what was the magic here that somehow made things different and better. And in addition to survival, 83% of those folks in the palliative care arm had a better perception of whether their disease was curable or not. And I said these were all advanced lung cancer patients. So none of these patients had curable disease. And 83% in the group who got palliative care had a true perception of that compared to 60% in the group who did not receive palliative care. And moreover, there was no change in the number of chemotherapy regimens that were given. The same amount of patients received phase 1 clinical trials. The same amount of patients received chemotherapy. The difference is when they received those treatments. So they were much less likely to get those treatments closer to death when they should have been receiving more end-of-life and supportive care alone. And so a big component of this was really communication. Was really sitting down with patients early on, getting to know someone early in the trajectory of their illness, and finding out their values, the things that were important to them, so that as they moved along in their disease trajectory and transitions had to occur from life-prolonging therapies to more supportive care, the docs knew what were important to them and could help make those transitions and help make those recommendations much sooner. And so communication is important. I think we have not only the evidence now to show us why it is important, but our governing bodies like the Institute of Medicine is telling us it's important. So in this report that was released last year, Dying in America, Improving the Quality and Honoring Individual Preferences Near the End of Life, I will say many of us wish this was just called Living with Serious Illness in America instead of Dying in America, because I think a lot of the principles from it pertain to both. But the point here is that they recognize in one of their recommendations that communication, teaching clinicians how to communicate, is a priority and should be made a priority. So, Cardi, that's great. You just told us I need to talk to my cancer patients. It's important. They want to hear about it. Well, how do I do it? Well, one of the things we'll talk about, and the intervention in this grant, is a riff off of something called OncoTalk, which was originally created as it was an NCI-funded educational intervention in which learners participated in workshops where they learned the actual communication skills and were able to practice it in role play sessions. And what they found was that, learners really increased their skills. Their skill levels increased across all of these areas, and that was statistically significant. I've had the benefit of doing this for 6 years now at Mount Sinai, communication training across many different disciplines and departments, not just in oncology. We started doing it for our oncology fellows in 2012. I don't have data from 2013. We didn't do it then because I was on maternity leave. But then we came back in 2014 and we asked the participants before and after questions about how well prepared they felt they were able to do all of these, what I would think people would think are basic communication skills. You know, the idea here is there aren't enough specialist palliative care docs to do this. There just aren't. And there's no reason to think that oncologists can't and shouldn't be doing this. You should be. But you need to have this, be equipped with the skills to be able to do it. And I think this is what we showed here, is that these skills are something that can be attained. The question is, how do you attain those skills and maintain those skills? And that's something that we're looking at with this grant that we'll talk a bit about. Overall, learners were very satisfied with the course. You can see here that the vast majority think this is something that should be required of all fellows, and they were all committed to continuing these communication changing behaviors that they learned. So that's Spike. Spike is going to teach you a template for how to communicate with patients. And this is a basic structure, a basic template that was created by Buckman and Walter Bale a while ago, and some of you may have heard of this before. But the S is for setting setup. That's making sure the people who are supposed to be there are there, and as much as you can have chairs so everybody's sitting down and no one's towering over somebody, that is preferred. The P is for perception. This is finding out what the patient and or family knows about their illness. I know we've talked a lot before and you've talked to other doctors. Can you tell me a little bit about what you understand is what you know is going on right now with your illness? Invitation. This is the checking in to make sure it's okay to give the knowledge, to tell them what you know. Would it be okay if we talk about what's going on now and how things may be changing? The P is for knowledge or medical updates. This K is either sometimes when you have to give bad news, when you have to give good news and talk about what that means, or give updates in how someone may be responding to treatment. E is for emotion or empathy, because these conversations, whether it's a conversation about things are going well or a conversation about things aren't going very well, are laden with emotion. And we'll talk a little bit about how you address that. And then the final S is a summary. This is what we talked about. You know, when you go home to tell your husband who couldn't be here today, what are you going to tell him we talked about, right? Sort of making sure, assessing their understanding and making sure they know what's going on and saying, all right, so I'll see you again in a couple of weeks when we'll start that new treatment. Now, the things to watch out for, you know, when you're going to give bad news, it's always nice to give a warning shot. You know, the news isn't as good as I hoped it would be. Unfortunately, right? Prepare them for what's coming. So I've heard so many times someone says, well, what does this mean? And the doctor will say, well, with this new immunotherapy, you have a 30% chance of responding. And if you're in that 30% chance, then the likelihood that you'll be alive for 2 years is probably about 15%. And like eyes glass over, and patients are sort of, what? I don't understand what you just said. So mix it up. You know, ask patients how they want to hear information. Do they prefer words? Do they prefer numbers? And then give it to them in a way that's very clear. You know, avoiding medical jargon, and then allowing silence. Silence is really important after you give the bad news. And so emotions. Emotions are hard for everybody. I know particularly I don't do very well with anger. So when patients are really angry because everything in the system failed them, and now it's my fault, that's really hard. That's hard for me because I didn't do this. And we've got to talk about the next step. I can't deal with the fact that you waited 5 hours for a CAT scan and then they didn't do it and you had to come back the next day. But I've learned through this next set of skills, which we'll talk about, called nurse, how to handle those emotions a little bit better. And so another really great acronym, nurse, is for naming. And this is where you just name the emotion. You know, you seem really frustrated. I can understand. I can only imagine how difficult it was waiting for that CAT scan. Respect. I'm so impressed the way you've been here every day to visit your mother. I have to tell you how strong you've been through these difficult times. Support. You know, don't worry, I'm going to be back to check on you. I'm going to be here through this next phase of your treatment and we'll get through this together. And then E, explore, which is sort of tell me more or what else. And even when things are going well, you can use these skills. So one of the things that I found really important, even when things are going well, is just to ask a patient, what's most important to you? given what's going on in your life right now, what's going on with your cancer, tell me what you hope to accomplish. What are the things that you're looking forward to? And this is a way to elicit someone's values. You may not get to finish the whole conversation then in that one visit, but getting that information can give you key details that you will need as that person's cancer changes, as the trajectory of the disease changes, so that you can use for future conversations. So, now for those of you who may be participating in this study, you may be thinking, oh, what am I signing up for, right? And what I hope you will think is, yay! So this is my almost three-year-old who started preschool in September. And I want you all to be as excited about learning as she is, because it is a very rare time, particularly for those of us who are faculty and attendings, where anybody cares about our learning, right? I mean, when you're protected as a student or a resident or a fellow, everybody makes sure you have time to get education and that time is protected for you. But when you get to this level, learning more is on your own, reading a journal article, right? And this is really an opportunity to improve the skills that you already have and to learn new ones. So, this is what the study is. We're taking oncologists, randomizing them to either usual care, so do what you normally do, or the intervention. So the intervention starts with this, thank you, and then you will participate in a 2-hour workshop learning some of these skills and practicing these skills in a role play session. And then you'll have 4 joint visits with your coach. And these 4 joint visits will happen in your actual practice. And so the way we've designed this is, you know, before we submitted this, we talked to lots of different oncologists to get a sense of when they felt like it was a good time to start having these conversations. And a lot of people felt as if that scan post-initiation of chemotherapy for advanced cancer was a really good time to start. So this is at the 2 or 3 month mark after someone's already started on their chemotherapy and they're getting their first scan, and things are either going well or things aren't going well. And we will have 4 visits with you for different patients where we will act as your coach to help guide you along through those conversations. And so some of you may be saying, what are you talking about, a coach? What is that? I'm not in sports. But I don't know how many of you may have, so clearly I'm an Atul Gawande fan. And I'm not sure how many of you read this article that he wrote about a personal best. So Atul Gawande is a surgeon, right? And he realized that when he was looking at his quality numbers of how well his surgeries were going, they were pretty good, right? He's pretty badass. He knows how to do these surgeries. You know, he can get them going really well. But he realized that his numbers were plateauing. And he sort of reached a peak and he wasn't improving anymore. And so he thought, I wonder how I can make myself even better. So he hired a coach. He hired a retired surgeon to come into the operating room with him and watch him, to watch his technique, how he holds the scalpel, how he dissects. I'm not a surgeon, so I'm making some of this stuff up. But you know, how he closes, how he interacts with the techs in the operating room. And really that person gave him feedback in real time while he was doing it so he could course correct, so that he could improve his skills and be better for the next time. And then that coach gave him some feedback after the surgery. You know, in addition to this is something you also could think about. You know, closing up, opening up this way, or using your left hand when you use this particular technique. And what he found was that after working with this coach for several months, he actually made improvements in his own personal scores. And so his personal best became even better. And that's the model that we're really going to be following here with this coach. And so your coaches will be Laura Morrison, if you want to wave. For those who may not know her, I would say that you are very lucky to have, and Laura's not the only one here, but are very lucky to have folks here who are experienced in teaching communication, because not a lot of institutions across the country have that type of skill set. And so you're truly lucky to be around folks who have experience, and take advantage of it. You have your own personal coach. And then I may be popping in from time to time, if you have me, to do coaching as well. And so what I hope to get away from is this cartoon, which I feel like I have seen far too many times poking fun at us as oncologists, which is there's no easy way I can tell you this, so I'm sending you to someone who can. We won't have to say that anymore because we will be expert in doing those things, and that's the hope of this. And so before questions, I wanted to do a little demonstration of what this would actually look like in real time in your real practices. So in case people can't hear you. Okay. So, Carrie. So I'm here from the PCORI study, talking about enabling goals of care conversations, moving them up earlier. Do you remember that? Mm-hmm. Okay. And so I read through Ms. Brown's chart. You don't have to tell me anything about the cancer. I already know about that. I'm really here just for the dialogue. I'm leaving the cancer care up to you. What do you think is going to go on in this visit with her today?
Well, I think she'll be relieved to learn that her cancer is stable.
Okay.
Got it. Okay.
Okay.
Did everybody hear that?
Yeah. Okay. Okay, great. That sounds wonderful. Could you add one thing when you're talking to her? Mm-hmm. Maybe just ask her what's important to her now, right now in her life.
Okay.
Would that be something you'd be willing to try?
Mm-hmm.
Okay,
Mm-hmm.
great.
Okay. Hi, Mrs. Brown. How are you today?
Good, good. How are you?
Good, good. So I just want to, I know you must be nervous, so I just want to say that we got your scan results, and it shows that the cancer is stable, that it has not grown or progressed.
Great news.
Yeah,
So relieved.
yeah, yeah.
Time out. Okay. All right, so now that's the encounter. Now this will be after. So how did that go?
Good. I think she felt good to know that the results of the scan were good.
Yeah. And you tried that one thing, what's important to you. How did you think that worked? How did that feel?
I didn't try it. I think it went well, and I think I learned some things about her that I hadn't expected.
Yeah, that's right. I mean, I think she told you about her family and how that was most important to her. And so I think that's, one piece of information that you could potentially use as you move forward. Great. I encourage you to keep trying it. I think it worked really well, and you have a really great relationship with her.
Okay, thank you.
Okay?
Okay.
All right. Now, stay here.
Yeah.
So now this is the same patient, Miss Brown, who unfortunately has progressed on her first line of chemotherapy. Okay, so hey again, Carrie. Good to see you.
Good.
So just as a reminder, I'm here again from that PCORI study, talking about joint visits to help enable goals of care conversations earlier. I'm here really only to focus on the dialogue and leave the oncology up to you. So what's going on with Miss Brown today?
So, she's really been struggling through treatment, and the scans actually show that her cancer has grown in her liver.
Yikes. Okay. So it sounds like you have to give her some bad news today.
Yeah, I think she might be very upset.
Okay. Yeah. How is that something that's challenging for you?
Very, very, yeah. I really hate causing the patient to feel distress.
Yeah.
Yeah,
It can be really hard then.
yeah. Especially when they've been trying so hard.
I'm wondering if you could try to ask her, what's important to her now that things have changed and we're in a little bit of a different place. And then I'm wondering if I might look for opportunities where she may be sad, and maybe I could add one thing, one of those skills that we talked about in that grand round session to see if it could help.
Okay.
Okay, great.
Hi, Mrs. Brown. Hi. So I have some bad news today. I know you've been going through a lot, but the scans show that the cancer has grown in your liver.
forwarding through the encounter. Come on over. Yeah. So that's just a brief sense of what it will be like for you, the oncologist. I fast forward through the actual patient encounter, which we could absolutely do if somebody has a grand desire to see it. But just to get a sense of, it's teaching you one new skill, hopefully at each visit, that you will be able to take away. And then we're really going to evaluate patient outcomes, particularly, did we improve goals of care conversations? And did patients receive care in line with their values and their preferences? And that's it. Happy to answer questions. You're all sold? My work is done.
So I think we've seen some preliminary results. You've been analyzing a lot of audio tapes of the baseline interactions between patients and their oncologists. Not here at Yale yet, but what are you seeing? What are some of the common
what Carrie's mentioning is that as part of this grant, we're assessing baseline audio recordings of the same potential encounter, and then we're using a validated skills checklist to get a sense of where docs are before our intervention and then what they do post our intervention. And I think what we're seeing is that, dealing with emotion is challenging. That, we often, as oncologists, sort of give lots of facts and information and seldom pause to get a sense of what the values are of that particular patient or how this may be impacting them as a person and their family and their life. Certainly the analysis isn't yet done for me to talk to you about skills in general, but that's the general gestalt of what we're seeing. Yep.
This is great. Thank you.
Thank you.
And I think one of the tensions here, and I'm sure actually I know it is at other institutions too, is this idea of who owns this conversation. And
Yeah.
so it is my approach is that the oncologist who's had a long relationship with the patient should be the person to open this discussion, and then the role of palliative care is to help continue the conversation and maybe go a little bit deeper than the initial conversation. I wanted to get a sense for you, is that part of how you're thinking about this process and how palliative care teams work with training or how it's separated from this training?
Yeah. So you bring up a great point. So one of the things, I'm going to answer your question with a little story. So one of the things Carrie and I did before she came here to Yale is help implement a required palliative care consult on our inpatient solid tumor service. So any patient who got admitted to our solid tumor service with advanced cancer got a mandatory palliative care consultation. And we saw improvement in outcomes. But one of the things that happened as a result of that really was culture change, because we have these interdisciplinary rounds in the morning at 10:45 where the oncologist, the nursing team, the social worker, the case manager, the PT, nutrition, and now Pal Care all come to the table to talk about this patient. And it really changed our education of our oncologists. So we use that as an opportunity to do primary palliative care education, to teach them about how to sort of invite that conversation. And what we found is that oncologists really are starting to invite that conversation much more. But then when they get to their challenging part, their stuck point, they can reach out to the palliative care colleagues to help them along. And so I agree. I think as an oncologist, it is challenging at times to have these conversations in in the limited time that we're given. What I argue is that if you have these skills and you can do these conversations well, that you sort of take the time factor out of it. And so I think what we're trying to do with this intervention is really inviting the oncologist to start these conversations and start them early. So there's still lots of life-prolonging therapy to offer, but we're starting it early so we can get a sense of who someone is, so that when that transition point comes, it's much easier for the oncologist to now say, we're in a different place. So I agree. Yeah. Mm-hmm. Yes, hey?
I know from talking to you earlier, you're also interested in racial disparities and those effects. How does that inform your discussion with the patient? Is there anything that you take more into consideration? And can you speak to some of the work that you've done today?
Yeah. That's a really great question. Thank you. It's interesting. I mean, I think there's this culture piece, which is sometimes a little bit different from race. And what we found, so we've been doing qualitative interviews with patients as a part of this study. And so far we have interviewed 20 patients. Our goal is to get to 40. And so far of the 20 transcripts that we've read and coded, patients say that it's not the doctor's place to talk to them about culture per se, but they do want their doc to know about them as an individual. And so, because disparities is an important part of what I do, what I have taken away and learned from my years of communications training and teaching is that if you approach every patient in the same way and you ask, how much information do you want to know? How do you want to hear it? Who is important to you? In my anecdotal experience, a lot of those differences go away. Now, there's been some work, although not large, looking at this as well. And that data has shown that when palliative care doctors are involved with minority patients with advanced cancer, that symptom burden that was higher prior to palliative care consultation sort of equalizes and normalizes after. And that rates of hospice use and other end-of-life care measures that in the literature suggests minorities patients may use less are actually used just as frequently as their non-minority counterparts. So I don't think this training has to change specifically for race. I just think we have to use these skills the same way for every patient.
Obviously, I'm really excited about the project, and I think what's compelling about it is the opportunity, hopefully, to really change outcomes for patients and their families. But I think the other thing that seems so compelling to me is the opportunity to change some of the physician-provider outcomes. I would hope that our colleagues could feel more empowered and have greater self-efficacy, not feel that they're getting stuck as often or in as many places. I just wonder what you're seeing so far and what we might be looking at in that area.
Yeah. So we haven't started this intervention yet, but I can say from my experience in the inpatient world that I mentioned, that I think that's true. And from my experience of training oncology fellows, so this year was the first year that we included nurse practitioners in our OncoTalk course at Sinai. And a week after, 2 of the nurse practitioners emailed me and gave me their experiences of dealing with someone and how the skills that they learned really changed their ability to have that conversation. And they felt, and from the nurse practitioner standpoint, they felt empowered that they could go in and do this without their physician, right? And then from the physician standpoint, from the fellows, I had one fellow say to me, every time I see this patient in clinic with Dr. So-and-so, she keeps saying, "Are you sure? How do you know? Are you sure?" She's like, and I used one of those nurse statements. I just said, you seem really frustrated. Tell me what's going on. And she laughed and said I named the totally wrong emotion because it wasn't frustration she had. But then she told me that she was just really scared about what that meant for her and about how long she may have to live. And the conversation totally shifted and changed. And that learner was then empowered to go ahead and do that again with another learner. So, with another patient. So I certainly have seen it anecdotally. What I hope to do with this is to prove it. Yes. Yeah. So I think social work has a huge role. I mean, I realize that social work's involvement, depending on where you are, is very different. At our institution, a lot of this is social work driven. And so my social worker will sit in with me when I have these conversations. And it is a way for me to open up that conversation to say, to get someone's values and preferences. And then I can turn it over to my colleague who has worked with me and that patient closely, and we all have a relationship, to then take it over and start talking about the next steps and what that means. And so I think that they have a tremendous role, and that's certainly at our institution how social workers' involvement, how they're involved. Yep.
Is the patient asked to include the care partner in the conversation, and do they usually want care partner?
And so in general, yes. They want their caregivers or their loved ones present in some format. There are some patients who feel like they need to get the information first to somehow protect their loved ones or their caregivers, but I would say the vast majority want someone present. And that's why, in that first S of spikes, we ask tell me who's important in your life, who should be here for big conversations. And that's sort of a little bit of what we're getting at with the what's important to you. So I get a sense of who that person is and may be.
So just a comment. I think the idea of being adult learners is something that we don't think about all the time. And I would say that just since working on this project, and I've never undergone formal UNCTAD training, but I've got spikes in my head, and I'll say that I'm getting better and better at goals of care conversations over the years, and that it's a continual process that happens throughout one's career, and that it's so important to just, I think, continually look back at what we do and what we could do better, and there are clear-cut structures that help. And so I literally go in and I think about setting it up. I now ask all the patients what conversations they've had with their other oncologists, so I know where they are and find out where they're coming from. And it's made a huge difference, especially in that handoff of care between an outpatient doctor and